Welcome back to Shades of Radiology. Today I am going to discuss a brief introduction about mucormycosis, its clinical features and imaging perspective. So let us see what is mucormycosis. It is mainly caused by mucorales, that is mucor, rhizopus and abscedia, and it is present in this normal environment and it is a serious fungal infection. And the main pathology involved in this mucormycosis is the tissue necrosis due to invasion of blood vessels, that is angio invasion. And what are the various forms of mucormycosis? That is the rhino-orbitocerebral mucormycosis, pulmonary mucormycosis, cutaneous and gastrointestinal tract. It can involve any organ within the body. What are the risk factors for mucormycosis? It usually doesn't occur in a normal individual. There should be some predisposing factor like uncontrolled diabetes, post-solid organ transplant, corticosteroid therapy, hematological malignancies, renal failure, patients on immunotherapy, and the most important thing is the post-COVID with or without risk factors. What are the symptoms when there is orbital or rhino-cerebro-orbital mucormycosis? I am going to discuss only this rhino-cerebral orbital mucormycosis. The main symptoms are severe headache, nasal block, bloody discharge, facial pain, toothache, eye or facial swelling, usually unilateral, then gradually it can progress to bilateral. How the clinical diagnosis is made? Usually by nasal endoscopy, that is the presence of black eschar. You can see here, this is the left nasal cavity, you can see there is a black eschar, and here you can see in the palate you can see this is again eschar due to mucormycosis. And nasal swab can be sent for culture and microscopy, and sinus biopsy can be done if it is indicated. Now why we should worry about the post-COVID mucormycosis, why it is become very common? That is because of various pathological factors that are implicated in this. That is presence of high ferritin levels, which makes the mucormycosis susceptible to the host. IL-6 drives the ferritin synthesis. Again, iron production is increased, which takes by the fungus. And endothelial damage due to COVID. Already due to COVID, there is a significant amount of endothelial damage that is leading to the pathophysiology of the COVID. And this leads to increased susceptibility of the host again to mucormycosis, and it increases angio invasion. So the final result is leading to angio invasion by mucormycosis. Coming to imaging aspect, MRI with contrast is the ideal or the choice of investigation to know the extent of involvement, what exactly is happening in the sinuses, whether it is extending into orbit or to the brain. And what do we see in MRI? That is mucosal thickening with irregular patchy enhancement with non-enhancing areas. This is very important. And coming to black turbinate sign, which is classically described in mucormycosis, which occurs due to ischemia and non-enhancement of the turbinates. Once there is ischemia, there is no blood supply to the turbinate, which leads to black appearance of turbinate on a post-contrast T1 weighted image. And coming to next finding, that is the thickening of the medial rectus muscle, which is the earliest sign of orbital involvement. So we should always carefully look for the medial rectus muscle, whether it is normal in morphology or not. And patchy areas of edema in premaxillary region, orbit, infratemporal fossa, and cerebral invasion gradually occurs in the later stages. And always look for the optic nerve, look for optic nerve edema, look for enlargement as well as enhancement on post-contrast images, which can describe that there is optic neuritis. And always look for the cavernous sinuses, where the spread actually goes from the orbit to the cavernous sinuses, leading to thrombosis, which again leads to ICA involvement and leads to infarcts in the brain. So this is one classic example which I wanted to show you is the non-enhancing content within the right maxillary sinus. Here you can see the anterior wall is invaded. There is erosion of anterior wall of right maxillary sinus. You can see the hypo non-enhancing area in the premaxillary region, and there is some amount of enhancement in the premaxillary soft tissue. And if you see here, there is again enhancement in the infratemporal fossa. And if you see the right maxillary sinus mucosa is not enhancing, whereas the left maxillary sinus mucosa is clearly enhancing. So this is again a sign of angio invasion leading to necrosis. So this is a classic case of mucormycosis. And this is one of the classic imaging sign which I described, that is the black turbinate sign. That is, if you see here, the inferior turbinate is not enhancing, whereas the other turbinates are enhancing clearly on post contrast T1 fat site images. And similarly, you can see the right middle and right inferior turbinate. These are two different cases. You can see again the black turbinate sign here. There is no enhancement of right middle and right inferior turbinates. So this is one of the earlier sign again in sinonasal nasal or mucormycosis, and it mainly occurs due to the devitalized mucosa, and it's mainly again due which we will be able to appreciate this devitalized mucosa is non-enhancement of the turbinate, which is giving appearance of black turbinate sign. And this is another case which we got recently, that is the 60-year-old male with left orbital pain. If you see here, you can see there is erosions of medial wall of left orbit. You can see the left ethmoid sinusitis, and if you see in the sagittal plane, there is an erosion of floor of left orbit as well, leading to invasion into floor of the orbit. And if you see here on post contrast images again, you can see some patchy areas of enhancement within the orbit. You can see the inferior rectus muscle showing enhancement, and these are the other images showing the same orbital involvement, that is early invasive fungal sinusitis leading to orbital cellulitis. And this is another case showing in CT. Again, this is a 40-year-old female post-COVID, came with complaints of pain in the right eye. You can see here, this is a normal extraocular muscle, that is normal medial rectus muscle. And if you see here, the medial rectus muscle is ill-defined and it's enlarged. It's clearly enlarged. And you can see the erosions of the again medial wall of right orbit and some amount of fat stranding in the extraconal fat space. And there is a right maxillary and bilateral ethmoid sinusitis as well. So this is again indicates that there is some invasive sinusitis which is going on. This has to be further evaluated and confirmed by the clinical diagnosis as well as with the microbiology microscopy. So there are various management for this, that is the medical or surgical. Medical management includes the control of diabetes, reduce the steroid usage, discontinue the immunomodulating drugs which are again a risk factor for mucormycosis. IV amphotericin B under supervision and other antifungals can be used. And when does the surgery is needed? If you see, if there is only sinus involvement, endoscopic sinus surgery can be done, which they do debridement of the mucosa, whatever it has been necrosed. And if there is a palatal and alveolar arch involvement, they do go through intraoral approach and do some partial maxillectomy. And if there is orbital invasion with vision or without vision, we need to classify the patients. If it is the vision is normal, then they do endoscopic sinus surgery with orbital decompression. And if there is no vision for the patient, if the vision is gone due to orbital involvement, then maxillectomy with orbital exenteration has to be done. And if there is a cerebral involvement, that is from nasal cavity or going into brain, then debridement is done by the neurosurgeon. Thank you all. These are the few references which I have taken from. You can go back and read for further advancements and the treatment aspect of mucormycosis. Thank you all.